and Education Program Coordinator with the National Center for Truth and Reconciliation. The topic for today's session is health impacts of the residential school system and other colonial systems, including the Indian hospital system, and the ongoing health impacts that we're still seeing today. We have three phenomenal guests with us today, our speakers, Kathy Pompana and Dr. Maureen Lux, and our moderator, Lauren Pelley. Just to give us a bit of housekeeping before I turn it over to Lauren to introduce our speakers, this is a Zoom webinar, so you'll see that the chat function is not enabled. And normally we would have a Q&A box, but we've run into a bit of tech difficulty today. So we're very sorry. What we will do is share an email address or two where you can send questions if you have. There are quite a few of you with us today, which is phenomenal, but it means we wouldn't have had a lot of time to answer questions from everyone anyway. So we also have to apologize because we do have ASL interpretation available. Malheureusement, il y avait un problème technique pour l'interprétation française. Je suis tellement désolée pour cela. On espère vraiment que ça va être réglé pour les autres sessions cette semaine. However, this session will be recorded and uploaded to the NCTR YouTube channel following this session. Our moderator, CBC's own Lauren Pelley, covers the global spread of infectious diseases, pandemic preparedness, and the crucial intersection between health and climate change. She is a two-time RNAO Media Award winner for in-depth health reporting in 2020 and 2022, a silver medalist for Best Editorial Newsletter at the 2024 Digital Publishing Awards, and a winner of the 2024 Covering Climate Now in the health category. So Lauren, thanks so much for being here with us, as well as you two, Maureen and Kathy. Lauren, please take it away.
Absolutely. I'm not sure if you're able to turn my video on now, so I can see everyone here. There we go. Wonderful. Thank you so much for having me. It's an honor to be here speaking about such an important topic with our esteemed guests in particular. Just going to introduce both of them now. Kathy Pompana is from the Sioux Valley Dakota Nation in Manitoba, but was born and raised in London, Ontario. She moved to Brandon, Manitoba in 2000 to attend Brandon University. Soon after leaving BU, she became an Aboriginal liaison officer in a federal penitentiary, where she began working with the residential school survivors who were incarcerated there. In 2012, Kathy left the penitentiary to carry on working with residential school survivors in the community. She's currently the Assistant Executive Director, Senior Resolution Health Support Worker, and Knowledge Keeper with Onish Healing Center, where she provides emotional, mental health, and cultural support services to Indian residential school, day school, 60 Scoop, and intergenerational survivors. Kathy has acquired many certificates and diplomas focusing on the effects of trauma and trauma recovery. Kathy, thank you for joining us today to share your insight in all of this. Dr. Maureen Lux is with us as well. She teaches Canadian history, the history of Indigenous government relations, and the social history of medicine at Brock University. Her book, Separate Beds, A History of Indian Hospitals in Canada, which came out in 2016, examines racially segregated hospital care and the impacts of that system. With no voice in their own healthcare, Indigenous people were forced by the Indian Act into these hospitals and kept there. Care was always compromised in overcrowded and underfunded ramshackle buildings operated in the interests of settler Canada. Her most recent book is a collaboration with Erica Dick in Challenging Choices, Canada's Population Control in the 1970s. They argue that reproductive policies were shaped by competing ideologies of global population control, poverty, personal autonomy, race, and gender. Dr. Lux's most recent project, in Inuit health and Kukalnat medicine in the 1940s to 1980s, is a critical analysis in the larger context of the 20th century's modernizing welfare state and the rise of medical authority to inform social policy. So in case you can't tell, these are two people with in-depth knowledge of this topic, and we're very happy to have them here today to dig into this discussion. So let's begin. if both of you could turn your mics on, I think we'll get going. So this is not some dark chapter in Canadian history. This is really an ongoing issue, and I'm hoping both of you can unpack, what the health issues, the illnesses and injuries and injustices that Indigenous people have been subjected to over the years, whether that's at residential schools, Indian hospitals as they were called, tuberculosis sanatoria, or other places. Can you give us a bit of a sense of just, those issues throughout history and how it's got us to where we are today?
Thank you, Lauren and Sandra, and thank you for inviting me to address this important issue. It's an honor to be included in the important work that's being done. I could talk a little bit about Indian hospitals. So they were government-owned, government-operated institutions. They were racially segregated hospitals. There was about 30 of them established across the country, mostly west of Ontario. And they operated from about the 1930s to the 1980s. The impact of the Indian hospitals, I think it's useful to think of, kind of impacts at an individual level on patients, and also the impact at a wider community level. As you noted in your introduction, the Indian Act was amended in 1953 by the so-called Indian Health Regulations that empowered police to force First Nations and Inuit patients to be seen by a doctor, force them into hospital, and also allowed the police to arrest anyone who left against medical advice. And so these were institutions that were established by the government in order to demonstrate to Canadians generally that the federal government was humanitarian, taking care of people's needs, whereas the hospital experience themselves was marked by coercion, long stays, invasive medical treatment, chest surgery, that kind of thing, where people were badly handicapped by their treatment and not necessarily their disease.
Kathy, do you have anything to add as well?
Yeah, I think my perspective is from the Indigenous perspective, and how we see and understand that the medical association from the time it began until now is that settler society believed that Indigenous peoples were naturally or inherently sickly because they believed that we were an inferior race. The forced relocation of Indigenous peoples onto reservations where we could not harvest traditional foods and medicines, and were forced to consume rations consisting of high carbohydrate, low nutrient foods, caused weakened immune systems, tooth decay, obesity, diabetes, cardiovascular disease, high blood pressure, cancers, and the list goes on. And I think, a lot of times people don't really understand that connection, that we had our own way of living and doing and being. And one of those ways was to eat, whole traditional country foods, and wild meats. And when those were taken away, especially in the Indian hospitals and in the reserve systems, they didn't allow us to eat those foods anymore, or it was very, very limited. Instead, we were forced to eat beef and like I said, milk and cheese and bread and those kinds of things that our bodies weren't accustomed to, which then created more problems. And then going into the Indian hospitals, like I said, it was just seen that, well, they're just an inherently sickly people, and so here we have to take care of them. And so from our perspective, I think it's more of them coming to save us in this. And there's a term for that which we use, some people might use, and it's basically the great white savior, right? And so that's sort of how we still to this day see that medical association, that medical perspective, as being they're trying to fix us and save us, and they don't know how.
Hmm. Um, I've personally had the honor of speaking to some of the survivors of these types of facilities while covering, the horrible legacy of Indian hospitals and TB sanatorium. And I remember people sharing with me, again, that sense of, they're being taken somewhere for medical treatment, and yet people were taken hundreds of kilometers from their homes into overcrowded facilities, lack of staffing, feeling detained on site, and people, sharing stories of physical and sexual abuse. I'm wondering, in your experience talking to survivors of people who've lived through this, what they've shared with you about this journey of being taken for alleged medical treatment, and what ended up being the result, the reality of these facilities in Canada that so many Indigenous people experience. What have you heard from survivors?
Well, what's the main thing that's shared is that, they were taken, a lot of were taken away from their families and communities to attend residential school as children. And then, taken from the residential schools to Indian hospitals for some kind of treatment, and not knowing what it was they were being taken for. And even if they were taken directly from their home to an Indian hospital, for example, they had no say in that. They had no choice. They were forced to go for this treatment. A lot of the survivors said, my parents would explain to them that we have our own medicines and we have our own way of healing this ailment. But like you said, when the RCMP were assigned to take care of those people, and to detain them and take them whether they wanted to go or not. And so they said, it was one thing to be traumatized, to be taken away to go to residential school, and then it's a whole nother trauma to be taken to an Indian hospital and being poked and prodded and not understanding the language, if they even spoke to them at all. Because I had some survivors say that they went to the Indian hospital for some kind of treatment and no one ever told them what was going to happen. No one told them what they were going to be doing. Like they do today, they explain everything as they go, but they didn't do that back then. They just took them and did it, and then punished them for crying or being upset about it after. And they say, it was just like going to the residential school again. So the impacts of those are we feel those today. That trust issue, there's a lot of trust issues, especially when it comes to medicine and Western medicine in particular, and what are they going to do, and why are they doing it, and I don't trust that, and that goes all the way back to those Indian hospitals and being forced to go there and undergo treatments that maybe they weren't even needed, because they did a lot of experimentation on Indigenous children and adults in those institutions. So they might have been undergoing, treatments and things that weren't even needed. It just, for their own benefit of finding out what would happen if we did this, or what would happen if we gave them that. And so that's what one of the things that was included in the apology that just happened last week from the Canadian Medical Association. One of the things that they included was medical examinations, and doing experimentation on Indigenous peoples when it wasn't warranted.
Maureen, do you have anything to add on that as well, from all the work you've done on your book and speaking to survivors, you know, just what people went through and the impact on them.
Yeah, so the Indian hospitals were by design overcrowded, underfunded. Most were in redundant military facilities, which were left over after the Second World War. And so those institutions were designed to treat soldiers, so men. So they were marked by large open wards. When Indian hospitals were, of course, operated as general hospitals in these institutions, they weren't renovated. And so you had large open wards with men, women, children, and all manner of illness. They admitted people for maternity, pediatrics, and tuberculosis in the same institution. And so the institutions themselves tended to be a vector for disease spread. The people were, as Kathy points out, over-medicalized. People were kept for very, very long stays, subjected to x-rays, repeated x-rays, and these began usually with young children on reserve. They were continued through residential schools where children were x-rayed, you know, had a chest x-ray at least once a year, more often. They were x-rayed repeatedly in the hospitals. And so the impact of this kind of ionizing radiation on the human body was understood by the 1950s, and that the larger recommendation was children should not have routine chest x-rays. First Nations and Inuit patients, of course, were repeatedly x-rayed. So this kind of over-medicalization that happened in Indian hospitals and residential schools had long-standing impacts on individual health.
I certainly want to get to those long-term impacts as well. And what I'm hearing from both of you is there's the spread of disease, there's the trauma on top of trauma being moved between these facilities, the medical experimentation, you know, quite a long list of injustices that people suffered in these facilities. And we're talking about a healthcare system at the time. So let's speak to the ethics of that. Can you sort of unpack, and maybe Kathy will start with you on this, just the ethics of running what was deemed a healthcare system meant to treat people, to keep people healthy and well was the notion, and yet obviously had quite the opposite results for Indigenous people across much of the country. These facilities existed in so many different areas. So can you speak to a bit of that?
Yeah, so you say, you know, that these institutions were created to treat people and to keep people well, when in fact for Indigenous people, that's exactly the opposite of why they were created. What they wanted to do at the time was to basically eradicate people. They wanted to get rid of Indigenous people. We were in the way of everything that they wanted to do, moving across the country. And so this was just another way of, you know, just basically having their way with us and doing whatever it was that they wanted to do. When it comes to ethics, you know, they wanted to show people, their people, that see, we're taking care of them, see, we're providing health care for them, see, this is what we're doing for them. But yet behind closed doors, what it was that they were actually doing, there was nothing ethical about it. And so the treatment, the experimentation, the ongoing over medicalization that Dr. Lux spoke of, you know, all of these things, that there's nothing ethical about that, and which is why the apology came out last week, because they know that they did wrong. All these years going way back, and that they had to apologize for those wrongdoings, because they take an oath of ethics to become a doctor. Right, Dr. Lux, you do have to take an oath and say that you're going to treat the patients to the best of your ability, and that's not what they did back then. There was no ethics.
Yeah, I would agree with those points. I think it's helpful also to understand that Indian hospitals were a part of a larger kind of colonizing web. One node, residential schools were another, of course. But even larger than that, the Canadian government's evolution of what we understand as Medicare is part of this whole story. So in the 1940s and 50s, the Canadian government instituted what were called national health grants. And this was federal funds that would match provincial funds for, among other things, building community hospitals. And it was wildly successful. So it's public funds that went into building community hospitals for the settler population. There was 300 hospitals built in the first decade of the program. And at the same time, there were the Indian hospitals that actively segregated Indigenous people from settler populations. And so the the national health grants created all these new hospitals for the settler population. But by the late 1950s, the costs of hospital care wildly escalated, and middle-class Canadians could no longer afford a hospital stay. And this led to the introduction of hospital insurance. And this is the federal government paying half, provincial government paying the other half of everybody's hospital stay. And it was important that Indigenous people were segregated. They were not part of this system at all. And so Canadians were assured that they would not spend time in a ward with Indigenous patients. So Indian hospitals are baked into the larger project of building national health. The department was the Department of National Health and Welfare, but it was very much a project of white settler health. And Indigenous people were recognized in the system in order to be effectively segregated into separate, racially segregated institutions. And so the Indian hospitals become a big part of that larger push to bring eventually Medicare in 1968 to Canadians. And so they are, Indian hospitals are a story that primarily impacts Indigenous communities then and now. But as Canadians, it's important that we understand that it was also a part of a larger system that Canadians, today are immensely proud of Medicare. It has its problems, but especially in reference to, the American system, Canadians are immensely proud of Medicare. But baked into that system was the segregation of Indigenous people in these separate hospitals.
And as we were talking about earlier, these facilities were shuttered over the decades, but they existed until the 80s. I feel like there were some that even existed into the 90s. Wasn't there a handful that lasted that long? So this was, a very long time with long-lasting ripple effects with this whole system of quote unquote hospitals. We can debate whether they should have even been called as such. So let's talk about, how this bridge from this past chapter of these hospitals existing to what we now see in the medical system today. We have Inuit people in Canada who are taken, very long distances for medical care. There's limited access in many parts of the country. You brought up earlier, Kathy, the trauma that still exists and the mistrust in our modern medical system. and rightly so, based on what people have experienced over the years. So let's unpack that a bit of, this legacy of the segregated healthcare system of sorts, and where it's led us today, where these hospitals don't exist anymore, and yet what issues still persist from this generation of how we handled healthcare in Canada.
Yeah, so I think that's something that a lot of people don't know or don't understand. Excuse me, is that if you're coming from the north, there's not a lot of places where you can go for adequate healthcare that you need. It might be a special type of scan, or something like that, or a scope that they can't do in the north, and they have to send those people down to Winnipeg or to Regina or to Edmonton or wherever they live closest to the major center. And so when you're in the hospital waiting room, you hear a lot of comments when you're sitting there as an Indigenous person about why is there so many Indians here? Like, oh my God, can't they just, go somewhere else? Or why are they always sitting here? They're all like always here. It's always full of Indians. They're always complaining about the number of Indigenous people that are sitting in the waiting rooms waiting to be seen. A lot of those comments, which I say this from experience, because I've had a few medical problems over my lifetime, and I've spent a lot of time sitting in waiting rooms and listening to these comments. And so you hear them, and it's kind of, they say it's sort of hush hush to the person they're with, but you can hear them clearly. And they had people make those kind of comments. And so I don't think a lot of people understand that they have to come south for certain treatments. And then while they're here, they have to be housed in hotels, because where else are they going to stay, right? And then so that's another complaint, when there's no hotel rooms available because they're full of Indians, right? So that's something that people don't understand, is that people from the north a lot of times have to come south for medical treatment. And so another thing, when what a lot of people I think don't understand too is, we're talking about Indian hospitals, and so this is from the past. And so the non-Indigenous people who remember those hospitals and remember, the tuberculosis and the diseases spreading and all of these things that they were told, or what they think they knew about the Indian hospitals, which most likely wasn't accurate or truth even. They tell those stories to their families, right? And those stories sort of get passed on intergenerationally. And so there's always this preconceived notion in families, in non-Indigenous families, that Indigenous people are sickly, that they carry diseases, that they that all of these things that get passed on through stories. So there's that. Okay. And then there's the whole issue of there's a lot of studies going on right now about epigenetics and what can be inherited from previous generations. And so there's a few studies going on right now, and we know a lot more now that certain things, that certain illnesses can be passed on, or that you'd be more susceptible to certain illnesses because your parents or grandparents had it, and that sort of thing. So we know a lot more about that now. But I think what, a lot of people don't understand is, those things that I mentioned earlier, the weakened immune systems, the tooth decay, the obesity, the diabetes, all of those things that the diet that Europeans brought and forced upon Indigenous people, they all create their own subsequent medical issues. Each of those things. Tooth decay can cause respiratory infections, diabetic complications, cardiovascular problems, kidney disease. And yet, many Indigenous people refuse to go to a dentist due to fear. And a lot of our survivors, actually, there's a lawsuit currently in the works. It hasn't been approved as of yet, I don't believe. But there's a lawsuit that's, about Indigenous peoples talking about incidents that occurred in the 60s, 70s, and 80s that involved removing healthy teeth for no reason, as part of dentist training programs, or just as, plain substandard care for Indigenous patients. Obesity can lead to other serious health problems: osteoarthritis, heart disease, stroke, type 2 diabetes, gallstones, cancers. Diabetes itself can cause many problems in nearly every organ in the body: heart disease, stroke, kidney disease, nerve damage, eye damage, dental problems, be more susceptible to infections, that sort of thing. So, we have to think, when people look at Indigenous people and they see us as being inherently sickly or unhealthy people, we have to go back and take a look at, well, why is that? Because we were at one time extremely healthy. And, but Europeans, when they came and they saw how lean and slender Indigenous people were, they mistook that for malnutrition. When it wasn't. It was just that Indigenous people were extremely healthy, because of the foods that we ate, the wild meat, and which is high in protein, and the root vegetables that are highly nutritious, and the fish, the clean fish that we used to have, not like today. It's with the mercury and everything else that's going around. So all of those things that were caused by colonization, all those medical issues were caused by colonization. It was caused by those things being forced upon us. And now we have, as Indigenous people, we face so many health problems because of that. And it's basically a legacy that we're leaving for our children. Our children, my children, are going to be susceptible to certain illnesses because my parents, grandparents, and great-grandparents went to residential school. So it's a lot bigger than what people might think. And this is where, the term that people use most often is, oh, they should just get over it already. It's a lot deeper than what people think. And it goes into this, now we're talking about healthcare, and which is something that maybe a lot of people didn't even think that this was going to be an effect of colonization and residential school and Indian hospitals and that sort of thing, to still have that effect today, until maybe, like I said, the apology that came out last week, and then people are now talking about it again, saying, oh, I didn't even think of that. So when the Indian residential schools came out with their lawsuit and their compensation process and the apology that followed, I think a lot of people thought that, okay, we can now sweep this under the carpet and just let it, kind of die, and it'll go away. And what it did was it just opened up a can of worms, because now we're finding out more and more about how it's affected and still is affecting us as Indigenous people.
Just to build off that for a moment, tuberculosis was sort of the reason for sending people to these sanatoriums. And yet the ripple effect of that, we can see in the data that Indigenous people remain dramatically disproportionately affected by TB. Like, many Canadians probably do not think of TB in their day-to-day life, but the overall incidence among Indigenous people is like almost 17 people per 100,000 affected by TB, compared to less than 1 per 100,000 for non-Indigenous people born in Canada. Like, staggering difference. And again, as you say, a ripple effect of what we saw over those decades. So I'm wondering if you can both comment on what we do now, because as you mentioned, there's apologies. There's been sort of a growing awareness of the fact that, there is this ripple effect. But what would you like to see done in the Canadian medical system and in our society right now to try and fix some of these issues and break this cycle of, people obviously having higher rates of many conditions, and as you said, dealing with feeling this mistreatment and this distrust of the medical system? How do we fix this going forward? Is there a way to do that? Maureen, do you want to start with this one?
Yeah, thank you. I'm not really qualified to talk about how the medical system should change, but I can help understand how these institutions, that were, as you say, shut down in the 1960s, 70s, and 80s, but that whole healthcare system continues to reverberate to today. For instance, the Indian Health Service that ran these Indian hospitals for the government had a policy that, yes, they would actively remove people from their communities into Indian hospitals, whether they wanted to go or not, especially, from the far north, but, across the country. So people were removed to these institutions, but those who didn't survive their treatment, those who died in hospital, unless the family could afford to bring them home, to be buried at home, unless the family could afford to do that, the Indian Health Service would not. And so Indian Affairs was then responsible, and folks were buried at the nearest cemetery. Oftentimes, at Edmonton, for instance, the Charles Camsell Indian Hospital was one of the biggest, with more than 500 beds. And patients who died there and their families could not afford to bring them home for burial, they were buried at the Edmonton residential school on those grounds. Others were buried on reserves. Others in local cemeteries, often with no markers, no ceremony. And that reverberates to today, where folks still don't know what happened to their people, especially the Inuit who were removed from the far north. There was never proper infrastructure, hospitals built in the north. And so the Inuit were moved south for treatment. If they did not survive their treatment, they were buried in local cemeteries, again, without proper record keeping. It was just last year that a group of Inuit survivors of the Hamilton Mountain Sanatorium were brought down south to visit what's left of the institution and to tour the local cemetery, where they found some of their own family. So those kinds of, that mistrust, that not knowing, continues to reverberate in families. Other impacts, when the Indian hospitals were eventually shut down, the thinking was that the Indian Health Service would then put those funds, give them to community hospitals, so that community hospitals could expand to include Indigenous patients. But that was very much resisted at many community hospitals and by provincial health departments, arguing that Indigenous people were best cared for by the federal government, that beds in their community hospitals did not belong to Indigenous patients. Indigenous patients were seen as somehow less worthy of care when they showed up at community hospitals. So those kinds of impacts are not easily forgotten in communities or by individuals. And, you could forgive people for approaching Western medicine with extreme caution and care, and at times, not approaching Western medicine for fear of how they might be treated in community hospitals.
And Maureen, I mean, this is really something we hear to this day from Indigenous community members about that treatment, different treatment that they may receive in the healthcare system. So, Kathy, I want to give you the last word on this. Is just, where do we go from here in our modern healthcare system, and how our society functions here in Canada? I mean, how do we improve things, because these issues, as we've discussed, have had a ripple effect to this day.
Well, I think the first thing is that we need to address denialism, which is something that is currently going through, the court system and through our government in trying to implement a bill or a law or something that where, when people are denying that colonization in residential schools and day schools and those sorts of things didn't actually happen. They weren't as bad as they were. That those kind of medical mistreatments didn't happen at Indian hospitals, that those things were good for us and were meant to help us, and that we didn't take advantage of those things in the way that we could have. Those things, those denialisms, first of all, have to be addressed and demolished. And then, trust has to be rebuilt for Indigenous people to feel safe and comfortable going into a hospital and to not go in there with their security blanket already up. Some people will say that, oh, well, Indigenous people they come in here and they're rude and they talk back to us and they use foul language and whatnot. But what they're not understanding is that why Indigenous people do this is because they've got their guard up, because they know that they're going to go into this whether it's a shop, an institution, a restaurant, whatever it is, a hospital, that they already go in with this guard up, that they're going to face racism, they're going to be not believed, they're going to be denied care or whatever it is, because they're Indigenous. And this is a trauma that has been passed on from generation to generation, and this is a trauma response. And so for an Indigenous people to be able to walk in and not have their guard up and not feel like they have to have their guard up, that trust needs to be rebuilt. And I can speak for, something that happened to myself when I went into a hospital and couldn't breathe. I was struggling to breathe, and they didn't believe me. And they basically said, you have the flu, go home and rest, you'll be fine. And so I said, okay, well, you're the doctor. I guess so, right? I believed them. I trust he's the doctor. Why would he lie to me, right? Why would he tell me something that's not true? So I went home and I struggled to breathe to the point where my husband basically had to carry me to the truck and take me to another hospital, where they said, what took you so long to come in? If you had waited another hour, you would have been dead. So because my lung had collapsed, that doctor at the other hospital didn't even listen to my lung. I was struggling to breathe, and he didn't even put a stethoscope to my chest to figure out what the problem was. He just said, oh, you have the flu, go home. And so that's how, and then after that, I had an instance where I knew I should have gone to the hospital, but I didn't. And it's because I didn't want to go and have to sit there and listen to the racist comments in the waiting room, and to be, have eyes rolled at me by nurses, and, be not believed. And I just didn't want to go through that. And so I didn't go, and I probably should have. Because right now there's a blood clot roaming around in my body somewhere that I don't know where it is, and one of these days it's going to catch up with me. And I knew that's what it was because I'd had one before, but I chose not to go because I didn't want to have to face those things at the hospital. So, the things that we go through as Indigenous people, these are very real things for us. And whether non-Indigenous people believe it or not, or they think we're over exaggerating or being dramatic or whatever, this is a reality for us. And these are things that we actually face daily in our daily lives. So not only do we have all these different medical problems and issues as Indigenous people because of what happened to us, way back then from colonization, that things that had been passed on epigenetically, and then being eating foods that we're not accustomed to, not being able to have traditional country foods. These things are causing us to be ill and to not be well physically and mentally and emotionally, because we know that food, taking in healthy foods helps us not only physically but mentally and emotionally and spiritually. And so not having access to those kinds of foods, it's cheaper to go to McDonald's and buy a meal. It's cheaper than it is to go to the grocery store and buy healthy whole foods. And so that's kind of where we're at right now, and we need to take a look at how are we going to fix that? How are we going to incorporate more of those foods that are nutritious for us as Indigenous people? Because right now, no one, I can't go to the grocery store and buy, a backstrap from a deer. You know what I mean? I can't go and buy a piece of, buffalo meat from the local grocery store. And so those are kind of some of the things that we need to look at too, because if we can start to become more of a healthier people through those sorts of things, then we're going to not need the medical system as much as we're relying on it now. Because another thing is that we're over medicated. As Indigenous peoples, we're taking multiple medications for multiple different things, and some of them actually interact with each other negatively, right? But because we're on so many different things and we probably see so many different doctors, this might not be caught. So that there's no easy, clean-cut answer to this. It's going to be a collaboration of different areas. Food sovereignty and traditional medicines and traditional healers, and believing those people. I know some elders who have actually passed away now, but they were spiritual people a long time ago, right? And they were sent to sanitariums because the non-Indigenous people believed that they were insane because they were speaking to spirits. We know that as being in ceremony and getting guidance from spirit, right? And so those kind of things too need to be addressed and looked at. So there is no clean-cut answer to that question. It has to be a collaborative effort, and everyone needs to be involved in that.
Well, thank you, Kathy, for sharing your own lived experience with all of us here today and giving us insight on that. And both of you for your academic work in this area and elevating the voices of survivors of these facilities. Thank you for such a fantastic discussion. We only have about 10 minutes left, and we have a lot of questions pouring in from the audience. So I'm hoping we can get through a few of these, and if you can keep your answers fairly short so we can get through as many as possible, let's try for that if we can. One of the first ones that came in was just, do we have a sense of the estimate of the number of Indigenous women, men, and children who were sent to Indian hospitals and other facilities? Do we have a sense? I know there's about 30 or more of these across the country, but the number of people impacted.
That's an excellent question. And I think, my estimate would be a lot. I don't know the numbers. What I do know is that these hospitals were always overcrowded. They were in operation for 2-3 decades. I know that when I was doing my research for the book, Separate Beds, when I talked to archivists, other historians, nobody had ever heard of Indian hospitals. But when I went to communities to talk to survivors, everybody had some experience, either as workers or patients or somebody in their family. So the institutions were ubiquitous. So my answer to that was a lot.
A lot. Well, fair. I mean, that's exactly what one would expect with just how widespread this was. I want to speak to, so another question that came in, someone has studied those higher rates of tuberculosis within Indigenous communities. And they noted that many studies in the area are not adequately considering socioeconomic factors or health inequities. And they place too much emphasis on genetics. And as Kathy pointed out, this perception that Indigenous people are sickly and things like that within the medical community. So what actions can researchers, medical professionals, and students take now to integrate history and social determinants of health into the assessment of Indigenous health? Would partnering with healers or community members be beneficial in helping us reach some solutions on this?
Yeah, for sure. I think just, taking all of this into consideration, and I know it's a lot to take in, but when you're doing that research and when people are trying to figure out, well, why are these Indigenous people so sickly? You have to go back. You have to go back into the past and see what that was. So when European people were bringing with them, flour and sugar and salt and things like that into our country, and they introduced it to Indigenous people and then forced it on us, through rations and not being able to hunt and fish and that sort of thing. Those things, just those three things are detrimental to health. The flour, the sugar and the salt cause just by themselves so many problems, right? And then so you have to go back into the history and really look at what it was that caused a lot of these problems and take those into consideration, instead of saying, oh, they're just inherently sickly, because that's not true. And it's not we can, I believe, as Indigenous people, get back to a place where we're extremely healthy, and I do believe that it's going to take time and effort and a lot of collaboration, but when you're doing that kind of research, keep those things in mind. And not only that, but the stress of being taken away from your family and community, this for a residential school, for example, the stress of being taken from your community to go down south for medical treatments, that anxiety, the fear, what does that do to the body, and how does that weaken the immune system, and how does that cause gastrointestinal issues, and what do those issues cause? It's such a ripple effect that I don't think people take it all into consideration, and you need to look at the larger picture when putting things together and trying to figure out solutions to things.
I wonder how much of this is in medical textbooks, like this sort of context for the next generation of medical professionals. I'm not sure, but I'd be very curious what they're learning. So obviously, the overt segregated system was dismantled, but a question about the current move to build Indigenous care pathways in healthcare. Someone is asking about hospitals are starting to build programs that ask at registration if an individual would like to be recognized and supported via a culturally aligned pathway. And this person has said staff and hospitals are concerned that by asking these questions and having these programs, we are moving to a form of segregation. I'm curious your thoughts on that. Is this a good avenue, or is this, as they say, moving us towards segregation of a different kind?
Yeah. I think one of the overriding issues in the work that I studied was this paternalism where the medical profession knew best, and so it did not much matter what the patient was saying because they knew best. I mean, even the Canadian Medical Association apology in part of their announcement was a small piece on the research that they did in their own CMA archive. And they found there was only 2 instances in 100 and some years where Indigenous people emerged to be a topic of discussion. And that was in the 1950s and 60s, the low pay that the federal government was giving physicians who worked in Indian hospitals. And they complained about the low pay. And the other issue was in 1968, when the Indian Health Service cut back on medical care for Indigenous people in anticipation of Medicare and the costs involved there. These were the 2 instances where the Canadian Medical Association found in its own archive that Indigenous issues came to the fore. And it speaks to 100 and some years of ignoring Indigenous issues altogether. And unless that is addressed in medical education, you know, before we get to the hospital itself, but in medical education, to understand the social determinants of health, that folks are sick because they live in overcrowded houses with mold and they don't have good drinking water. You know, those kinds of social economic issues that persist. Those health disparities persist today that were found in the 1940s and 50s. To remove people to hospital, to make them better and return them to the very poverty that made them sick in the first place, almost ensures that there will be ongoing health disparities.
Kathy, any thoughts on that as well, particularly on, you know, the notion of new hospital programs, asking people if they want to be culturally supported? You know, is that bringing us back to that type of segregation? Is it moving us a step forward? What is your take?
It's hard to say because it could move us forward. It really could, if done in the right way. But what I would be afraid of it, again, turning into that segregated different, right? Because all people, no matter who you are, where you come from, what color you are, should be treated equally. And by equally, you know, we have our ways of using medicines, traditional medicines, and we know our healers, our medicine people who are gifted with those abilities. They know, they can tell us what we need in collaboration with Western medicine and how that would work for us. And so I think, you know, including these people in these healers, these medicine people in on somebody's healing path would be very beneficial. But then again, who, like, I don't know who's hiring these people. I don't know where they're finding them, you know, kind of. So it's, I caution it a little bit as an Indigenous person, because I just don't, again, there's trust issue there, right? So is it the hospital that's going and interviewing people and just saying, well, sounds good to me, sounds right, it sounds like they know what they're talking about? Or is it Indigenous people who are engaging in this? And who are those Indigenous people? There's so much to it. There's so much that needs to be considered. And I think it could be beneficial, like I said, but it has to be done in the right way, or else we're going to end up back in that segregation. And what happens when people know that there's when non-Indigenous people know that there's a separate a separate road that is laid out for Indigenous people, the first thing that they think of is that it's just a waste of money. That's the first thing. It's just a waste of money. They're not going to follow through with it anyway. They're just going to leave here and go and take their pills, and then they're going to go and get drunk, and then they're going to defeat the purpose. There's so much racism and denialism that's happening today, and a lot of people say, oh, I never hear anything racist. I never hear anybody say anything racist. I never hear anybody deny. Well, but we do. As Indigenous people, you might not be hearing it, but we do. And so we have to be careful with those kinds of things that are being implemented. And again, like, there's that trust issue too on our side. So who's implementing them? How are they implementing them? What is it going to lead to? Those are all very good questions.
Well, thanks to both of you for sharing so much insight on this and where we go from here. We are out of time, despite having so many wonderful questions. I'll hand it back to Sandra to wrap us up.
Yes, first, let me just express on behalf of the National Center for Truth and Reconciliation my our sincerest thanks to all of you, including the interpreter, for your time today, for sharing of your expertise and lived experience. I can say that Lauren got every single question that was emailed in, and there were around 40. So thank you. So sorry that we haven't had a chance to address those directly here. Some of those we will answer ourselves directly by email. So those have all come in. This session will be uploaded fairly immediately to our YouTube channel, where you should be able to see the interpretation for the first part before we were able to get that going. So apologies again for our technical issues today. We think we have them sorted for the rest of the week session. So hopefully we will see you tomorrow at 12 Central. Thanks everyone for coming today.
Thank you.
Thank you.
Thanks all.